Good morning, everyone. So for the past 4 years, my colleagues and I have had the opportunity to participate in the ambition to understand the clinical picture of long COVID, while bioscientists have explored the pathophysiology of symptom persistence. Thank you. We clinicians have had the privilege to meet these patients, develop explanatory models together with them, and most of all, discover ways to promote recovery. Before I go further, I would like to know who of you here in the public know someone who has recovered from long COVID. You can just put your hand up. Okay, seems promising. Here are my conflict of interests. And as our time is short, I will move on to the presentation itself. So during the following 15 minutes or so, I'll give you a brief overview of what we've done in this long COVID EU project in our clinical studies. And I will share our practical experience. So we've had 2 patient cohorts in the study and also a prospective population cohort in the Netherlands, which I will not concentrate on today. I will concentrate on our patient cohorts. So in Finland, in the Helsinki University Hospital, we've had a cohort of about 450 patients, and then we've had 200 controls. And in the Switzerland University Hospital Basel has had a cohort of around 200 patients. And for these patients, we have analyzed broad parameters, blood parameters. We have performed physical function tests, neurocognitive assessment tests, and we have also collected patient-reported outcome measures, lots of questionnaires for the patients at baseline and at 3, 6, and 12 months after entering our study. And as Giuseppe just mentioned, we have gathered all kinds of other omics and stool sample, etc., oral rinses. So really try to look at everything. And for our studies, we have used the World Health Organization definition of post-COVID condition, which in addition to the criteria about length of symptoms, etc., says that this condition should not be explained by another disease. So here you can see the baseline characteristics of our patients. About 3/4 of our patients are female and in their mid-40s. Within our cohort, the patients had a tertiary education more often than in the population in general, which should be considered when thinking about the generalizability of these findings. And in general, all routine laboratory results did not show significant differences between patients and controls. But what really differentiated patients from controls was the number of symptoms they reported. So at baseline, the patients in the whose cohort reported 20 out of 35 suggested symptoms. And in Basel, they reported around 14 out of 24 symptoms, whereas controls reported 6 out of 35 symptoms. And what else differentiated our patients from controls was the quality of life that they experienced, which of course goes as a natural consequence of being so symptomatic. And here are the most common symptoms that our patients have reported. I've listed the top 10, so to say, from both Basel and Helsinki patients, with the Helsinki patients on the top. And as you can see, they're the very typical symptoms: exhaustion, fatigue, sleep disturbances, dizziness, headaches, and muscle pain, limb pain. And with the physical function test that we performed, we tested, for example, hand grip strength, which did not show a difference between patients and controls. But the 6-minute walking test, where patients walk for 6 minutes and then you measure the distance, that showed a significant difference between patients and controls. Controls walked a significantly longer distance than the patients, both in HUS and Basel. And we were also able to see, let me use the pointer here. So here in this graph, you can see that the length, the distance, the length of the distance that they could walk correlated to their reported functioning. I'll just set the mic a little. So, as Giuseppe also mentioned, persistent symptoms after an infection is not a new thing. And we could also see within our patients that and as you probably most of you know, the symptomatology of long COVID is very much shared with the symptoms of chronic fatigue syndrome, which can be triggered by a virus, but it can also be a consequence of something else. Also fibromyalgia, functional neurological disorders, environmental intolerance share symptomatology with long COVID. In the Helsinki University Hospital, we also have gathered data from a cohort of patients which have persistent symptoms caused by something else, not long COVID. And what we could see, maybe I will use, no. I think I should, yeah, maybe I should use those. No, I'm just thinking that maybe when I use my pointer, the ones following through the internet cannot see it. Yeah, so, yeah, but just to continue, so we have looked at a reported symptom-related distress and preoccupation with symptoms among both long COVID patients and the ones in the other cohort of patients who have persistent symptoms. And as you can see in the green and blue colors, their profiles overlap significantly and differ from the ones of the control patients. So what this suggests, yeah, maybe I use this. So there is most likely a shared mechanism and also overlapping therapeutical pathways that we should think of. In addition, this supports a multidimensional transdiagnostic view of persistent symptoms. So as we all know, many hypotheses on the explanations for long COVID emerged already since the beginning of the pandemic. And in our clinic, we quickly saw that our patients' symptoms are multifactorial. And in 2023, when this article was published in Lancet Respiratory Medicine, that explanation really resonated with us in our clinic. And this article, the authors of the article argue for acknowledging these like multifactorial reciprocal relationships between triggers, conditioning mechanisms of the brain, and symptoms. So we thought that we would like to hear patients' thoughts about this model as well. And we started an infographic study. We put this model into an infographic and used it to explain our patients' symptoms. And then we collected data on how they experienced this explanation. Was it helpful for them? Was it not? And how well they thought it explains their symptoms. And data of the study is still to be analyzed. Sorry, I don't know, this pointer doesn't seem to work now. So this study was done together with patients at the consultation. In addition, we had clinical interventions. In Helsinki University Hospital, we started an AIR trial, the so-called AIR trial, which is a randomized controlled trial with 3 arms. So patients were randomized either to treatment as usual or a therapy called amygdala and insular retraining therapy, which is a mindfulness-based internet-delivered program, and another cognitive-based therapy developed in Helsinki University Hospital for patients with persistent symptoms. Our primary outcomes are functional ability and quality of life at 6 months, and we have closed the study in November last year, so we will first be able to open the code of the study in June, and we're really expecting that. And because we wanted to understand our patients' experience of these interventions better, we also started a study of focus group interviews where we interview these patients in groups and try to really understand what they find helpful in these interventions, what is not helpful. And we could hear from the patients that there's a really huge variety of how they first of all perform the interventions. Many of them have their own variations of the interventions. And what we could hear from them is that the ones who had adopted this more holistic approach to their condition really seem to be getting better effects. But we need to report this study. It is still to come. Our colleagues in Basel developed a digital intervention tool. Their trial is called the DILCOS trial. It's a single-site feasibility and clinical evaluation study, which is also based on a holistic multidisciplinary approach and contains educational and interactive components, and patients can also customize it to their own needs. Also, in this study, the primary outcome was post-intervention functioning, and we are also expecting a publication on the results of this study. So in terms of prognosis, I was actually surprised when preparing this presentation. I tried to search for studies reporting prognostic factors that relate to recovery, but I mostly found prognostic factors that relate to symptom persistence. Within our own study, it was a preliminary study because all of our cohort patients had still not reached the 12-month follow-up time. We could see that in the beginning of the study, the mean number of reported symptoms was 20, and at 1 year, patients reported around 15 symptoms. So there was some decrease in symptoms during the 1 year, and we also measured quality of life with the EuroHIS patient-reported outcome measure, and there we could see that when at baseline, about 9% of patients had a good quality of life. At 1 year, they were already 33% with a good quality of life. Well, having said all this about prognosis, we have read, luckily, also reports on interventions that are based on cognitive and also behavioral change, and they have some promising results. Importantly, recovering patients have collaborated to bring hope to others. So, as a result of our project, we have developed an infographic that explains long COVID from this broader systematic system-level approach and incorporates current neuroscientific understanding of symptom persistence. The model is based around our bodily defense mechanisms. So our brain, our autonomic nervous system, our hormonal systems, our immune system, they all work together, and their main aim is to protect us. And when we are threatened by a virus, for example, these systems activate and they function together. And for some reason, in some patients or some people, these defense mechanisms might not set off as they should, but this defense activation might continue even after the acute illness resolves. And there are many predisposing factors we can recognize for this. But when this happens, our brain is sort of left in a defense mode. And then it starts to interpret things that might not be threatening to us as threatening. And that naturally causes symptoms and behavioral change, which again might cause symptoms. And that becomes a cycle that luckily can be interrupted. So when you think about these processes from a system level, it's not difficult to see why many factors can affect this defense system, not only the virus, but everything we encounter. As Giuseppe said, everything that we perceive, everything that we encounter has a biological effect on us and can sort of participate in this prolonged defense response if its function has been altered and in a way sensitized. And that's the reason why we see like long COVID as a multifactorial condition. And multifactorial sometimes might sound like there are many things that we need to change, but actually multifactorial is also, there are many opportunities for change. So it is really important to consider what are the individual's factors and what influence the single individual, and what are the factors that we can affect, and we can increase the person's agency and give them hope. Because as we also saw from my first question to you, there are many who do recover, and we should really learn from them as well. So to sum up, symptoms are real and cause substantial impairment. However, in the absence of a biomarker, a system-level approach that integrates brain-body defense mechanisms is both justified and necessary. If we ignored it, what would happen? And would we really be able to provide what our patients need? Explanatory models are interventions. They're not just communication tools. And as I already said, recovery is possible. Thank you.
We have time for one quick question again. There is some question, or there might be some opportunities during the coffee break as well to discuss with the speaker. One question. Yes, one question from you.
Quick question myself, similar to what was asked before.
Yeah.
Is the reverse of the question. The interventions that are working, have they been used a similar approach for other diseases, and they also work?
Yeah, definitely. And that also strengthens the understanding that these are multifactorial and they share the symptomatology, and also the interventions that we can use are the same. Of course, they need to be adjusted to the individual, but in general, the same approaches are sort of shown to be the most effective. Yeah. Yeah, please. One more question still? Yeah. I can give you this one.
Velina, thank you so much for that lovely summary. The diagram with the circles, is this a new thinking in this area? Have you seen other diagrams like this with other chronic fatigue conditions? How did the diagram come about?
Thank you for this question. Yeah, it's not in a way new thinking, but it's maybe presenting the old thinking and the evolving thinking and the updated thinking also from the perspective of long COVID, and summing it up also for our patients. So the thoughts were not made within our project. I wish they were, but some wiser people with years of research have come up to these mechanisms, and we have just integrated them and updated them with the knowledge that we have gathered in our project.
I like them a lot, and
Yeah.
I thought that was really good.
Yeah.
But I'm thinking back to Hurry and 1914 with the vicious cycles of neurasthenia helped by exercise and psychotherapy, which Michael is a. And you've got the circles in, which is very, very simple, isn't it?
Yeah, but yeah, isn't everything sort of a circle in our life, having effect, things having effect on each other? Yeah.